Hello, I'm Chad Naughton, Professional Relations Manager with 3M Oral Care. Welcome to today's broadcast, a clinician's guide to cementing and bonding contemporary dental materials. Today is part one of a two-part series, Science and Applications. Today's broadcast is brought to you by 3M Healthcare Academy, where you can find a wealth of educational content in a variety of flexible formats. Dr. Dan Poticny has been in private practice in Grand Prairie, Texas since 1983. Over the course of his distinguished career, he has held positions as a professor, adjunct professor at the University of Michigan, and he's received numerous awards and recognitions for his expertise in CAD/CAM dentistry. Dr. Poticny's practice philosophy and approach to dentistry can best be summed up with the statement, the trained professional has merely earned the right to become a student for life. As a reminder, not all products are available in countries. Product names and packages may vary from country to country. And for more information, please contact your local 3M rep. This webinar was prepared and authored by Dr. Dan Poticny. The opinions expressed in this presentation are the author's own and do not necessarily reflect the view of 3M Oral Care. Ladies and gentlemen, Dr. Dan Poticny.
Welcome. The objectives of today's program, and at the conclusion of it, we will understand how to categorize permanent dental cements, properties of these cements, and the adhesive strategies necessary for metal and ceramic, using metal and ceramic primers, total, self, and selective etch. Also, the control and peripheral aids necessary to ensure these good outcomes that we all desire, and universal adhesives in general. So here we are, LUT. What does it mean? It's a very common term used in dentistry. And if you look at the definition of it, it means simply to seal, join, or coat with LUT, which is really what cements are all about, or cementation is all about. So in looking at this, let's take a quick history and let's look at permanent dental luting agents, or cements, if you will. The gold standard probably now, till this day, has been with us for nearly 100 years, and of course that's zinc phosphate. Most of us have grown up using zinc phosphate, and it is still in common use today. To say that it has been unreliable would be a misstatement. And I think all of us can remember on occasion using zinc phosphates, typically telling a patient, you know, it's going to be a little bit sensitive here for a while, and the patient had the expectation for a couple weeks it would be, simply because these categories of materials are acid-base reactions. It took a little while for the acid if you will, for the body to accommodate to the acid, and over time, the patient would have very good results. But today, in today's world, and using the materials that we are now accustomed to using, zinc phosphate is not a capable material. So in 1987, the resin cements were typically developed and are very common use today. We're going to talk about these cements. And of course, in 2004, the first self-adhesive resin cement was brought to the marketplace. And this is a very popular cementation protocol for dentists today. We're also going to discuss the resin-modified glass ionomers, which are also in common use today. They're very capable to that end. In truth, we're probably looking at the end of the use of zinc phosphate cements simply because of the fact that the delivery protocol for these particular cements involves simple mixing. In titrating the acid correctly and getting it to the point to where we have the right consistency is now been, if you will, accommodated for by the manufacturers in the self-mixing or the delivery systems that are currently available to us today. So let's look a little farther and talk about clinical challenges. And I'd like to call it simply risk versus reward, because predictable outcomes depends on dentists understanding the material, the requirements for the luting agent at hand, and then if you think about all the materials that we have out there today, should we adhesively bond the material? Should we look for a weak adhesive bond, a strong adhesive bond? And then what technique should we use to treat the tooth surface itself? We have the technique of total etch, which has been with us for a long time. Now we have the self-etchers, and we have another technique called selective etch. Additionally, we have different types of procedures. How do we handle crowns versus partial coverage restorations? What about things like Maryland bridges, cementing post? And as you can understand, it creates a lot of confusion among dentists today, understanding that there is not one simple answer to any of the above. So hopefully today I can simplify these things for you and give you a good understanding for hopeful Monday morning results. The requirements for dental cements in 2016 have to address the wide-ranging applications that are out there with respect to the materials that we're commonly using today. We all want long-term outcomes, and we want good clinical success, but we want to be able to have that success usually in a very simple fashion. In other words, something that's repeatable, that we can constantly reproduce easily in our dental office. And in addition to that today, these cements can also influence the overall aesthetics of the materials that are commonly associated with the silicate materials or the glass ceramic restorations, if you will. So how does a clinician choose? Where do you start? Well, it's a question that is, well, I don't have a real answer for that, because if you talk to clinicians, and as I have over the years, some people are just beholden to a particular manufacturer. Other people talk to their buddy down the street and say, hey, what do you use for this? How do you do this? Other people take a scientific approach to what they do. I think a good place to start is to look at the companies that have been in the marketplace for a long time. And I think all of you can see here, as I put up a number of these companies that are available to us, some of them have long clinical track records, others don't. Some of them offer cost as an alternative to expensive materials that are out there. I think realistically, though, what a clinician should really focus on is to look first of all at the company and how well you're going to be supported. I think you should also look at how well you'll be supported in the field, because that's very, very important. The last thing you really want to rely on when choosing a product in a dental practice is to rely on the distributor, if you will, and the sales rep that calls on you, because their understanding of clinical dentistry is frankly not that good. So the last thing I would say, too, is that it really helps, and I think the companies are doing a better job of this today, by giving doctors the ability to understand how a category of product with a nomenclature or a naming system, if you will, making it easy to understand how to choose a product for a specific or given clinical situation. How does a clinician choose? Well, other doctors, as I mentioned, I alluded to this in the previous slide, is that many doctors do chair-side research. And by saying that, I mean it's a bit of alchemy of sorts, where doctors try to mix things in products in the hope of perhaps saving cost, or maybe a colleague of them told them, you know, if you use this with that, it can actually work, this type of thing. The problem with doing these kinds of things, and I can tell you in doing research of my own, is that when doctors attempt these things, they have no realistic way of having a control to judge the results by. And unfortunately, it results in them many times changing technique or adapting techniques because of something that another colleague may have told them, well, no, if you try this, it tends to work, you know, and all this type of thing. You wind up compromising your outcomes. And in the process, what can eventually happen here, you can be doing the same things many times for years until the bad outcome comes, and then you're looking at a long track record that's going to produce failure in the long run. So I would encourage you to get away from this type of chair-side research and instead focus more on what we know about clinical dentistry. So to understand cements, there are a plethora of cements that are available out there in these current cement categories as you look over here. We have the polycarboxylates, which have been with us for quite some time, and actually were a nice way of addressing the things that zinc phosphates couldn't do. Unfortunately, with polycarboxylates, they tend to be a little bit thicker, and film thickness is a critical element in what we do today with a certain number of the restorative materials that are common in a dental practice. Glass ionomers were the first type of material that actually developed a higher level of bond. Granted, polycarboxylates actually did some molecular bonding to tooth, but with the advent of the resin-modified glass ionomers, we had a lot of the nice features of the glass ionomers with the reinforcement that came from the resins, making them typically a better choice than purely the glass ionomers alone. And now as we enter into the era of the self-adhesive resin cements, and now the adhesive resin cements using dental bonding agents, you can see that the elements that we require, which are retention and bond strength, which, by the way, are the most common things dentists will look for when they choose a cement, because failure is typically associated with what? The loss of the restoration. But dentists have to be more pragmatic than that today, because we have to consider these other properties, and it's really not strictly only about retention of the restoration. You see here in need-based choices, when we begin to look at other things like moisture tolerance, all right, ease of use, and mechanical properties, which I believe today doctors should have a much better understanding of, because it's going to relate to the overall performance of that restorative material. Moisture tolerance is a critical element because many of us require short operating times or short levels of performance towards the bottom of this chart. As you can also see that the complexity or the risk associated with the placement of the restoration goes up because of the time element that's involved. So let's begin today by talking about dental and enamel bonding, the basics of adhesive principles, total etch, selective etch, self-etch. Which should we use, what, when, and where, and how does it apply to us? I'd like to keep this relatively simple in understanding that this is not complex, and hopefully address some of the concerns and some of the problems that doctors have had traditionally when using any one of these three techniques. In retrospect, if you look at the development of adhesive dentistry, and this was earliest described by Buonocore in '55, so what are we, 60 years on down the line over here. The gold standard for bonding in dentistry is now associated with what we call the three-bottle system. And arguably, if you look at this chart here, and this is a compilation of a number of published studies that are out there, when you look at the tensile bond strengths of various classes of materials, most of us are familiar with this generational approach towards things. For instance, the generation 4 products involving the three-bottled system. You had an acid, you had the primer, and you had the adhesive. And if you look at the overall values, you can see clearly that as we developed easier to use systems, there tended to be a drop-off in the level of adhesion that we had to dentin. And this was done for a variety of reasons. One was simply associated with the fact that it was a complex procedure. 3 bottles here, how do I use it, for how long? And I think a lot of dentists just say, you know, we've got to have something just a little bit more simple here. So in understanding this, if you think about it just for a moment, shouldn't it be the, if you will, the desire of all of us, if we're going to go through the trouble of adhesively placing something to a tooth, I would think it's reasonable to ask or to be able to say, I want to reach for the highest values that I possibly can. And the two approaches to dentin bonding have involved two very simple concepts. As all of us know, when we cut on a tooth or we repair dentin, we're going to leave behind the slurry, if you will, of dentin and particles that are associated with grinding away the tooth structure. And the total etch technique, which was developed initially, was the technique was for its success depended on the removal of this actual smear layer, the exposure of the dentinal tubules, and the ability to keep the collagen in a moist or fluffy state to promote the impregnation of the primer and eventually the adhesive in the tooth to seal the tubules and form what we call a good hybridization zone for bonding. In looking at the total etch technique, and if you look at the smear layer that you see here, the phosphoric acid, which has a very acidic component, a pH of less than 1, was applied to the dentin and to the enamel for anywhere from 10, 15, 20 seconds or longer. And once removed, the stated technique was that this hybridization zone, which, by the way, everything in adhesive dentistry when it comes to success, depends on a very narrow layer. Think about it just for a moment. 5 to 15 microns, that's roughly, one blood cell is about 5 microns. So if you think about that, this is where success, or the rubber hits the road, so to speak. You've got to maintain and develop this hybridization zone to have success. And as you look at the dentin over here, this is the ideal situation for producing reliable results with total etch technique. Open dentinal tubules, and you can see the collagen obviously here is in a very good state. It's upright and appears to be fluffy. But the problem, if you will, with the technique, and the reason a lot of the manufacturers went to developing products that went beyond the 3-bottled system, was a very common complaint that phosphoric acid caused tooth sensitivity. Now, I have to be quite frank with you that it's not a result of what you would say is phosphoric acid. More to the point, it's the misuse of phosphoric acid and perhaps the complexity associated with the 3-bottle technique. If you think about what causes tooth sensitivity, there are many factors. Many times doctors will ask me, help me out here, because I'm having sensitivity with the techniques that you seem to have really no problems with. And I think beyond the fact that there's a technique issue perhaps associated with these systems, we have to think about other things as well. Tooth preparation, the age of the patient. As you all know, older patients are certainly more tolerant of trauma to their teeth because they have, the pulps have receded away. They have fewer dentinal tubules. And if you think about the preparation itself, many doctors just heat the tooth excessively, use worn cutting instruments, a number of other things. There has also been some discussion about bacterial contamination, fluid contamination, commonly from saliva and blood. But I would suggest to you that more commonly, the most common culprit is technique and execution. And that's what I'd like to discuss as the following. Because in a total etch technique, if you overdry the dentin, what you're essentially going to have is a collapse of the collagen network. And as you can see here clearly, where we have the odontoblast kind of barking at you, if you will, what's actually happening here is described by Brandstrom early on, where we get a fluid shift in the dental tubule to any stimulus to the tooth. And the stimulus could be nothing more than cold, it could be heat, and it could be simply changes in air pressure. But the end result for the tooth was it produced pain. And the reason for this is that the collapse of the collagen created an improperly or absent formation of the hybridization zone itself. And as you can see here, it's clearly different from the previous slide that we saw, where we see open dentinal tubules, but we see absolutely no collagen network available for the technique to properly perform. And in looking here at this slide, it's very, very clearly what the hybridization zone looks like under scanning microscopy. Because on the left over here, you can see clearly tags into the peritubular dentin. But on the right side over here, you can see the same, but you can also see a distinct hybridization zone. And this is the critical element to produce the end result that we're all seeking. So, what changed? Well, in pursuit of the sensitive-free, properly bonded restoration, manufacturers develop a technique where we now eliminated the phosphoric acid. So essentially, the primer was combined with the adhesive, and the primer is weakly acidic, on order of a pH of 2 or higher. And the stated aim of this particular technique is by agitation over the smear layer, which is left intact, a partial demineralization of the smear layer would occur, allowing for the adhesive to infiltrate in forming a network, thereby not removing the plug, which was left intact from the smear layer, and sealing it, if you will, as a part of a complex. The odontoblast had no opportunity to have a reaction to fluid shift because they weren't open in the first place. And it's a very, very tried and true technique, and the argument can be made today that at least for self-etching and dentin, it's a very effective process, as long as the technique is followed correctly. And this complex, as you see here, is formed, and it produces very good results. When you look at scanning microscopy and you look at the hybridization zones created, it does actually quite a good job. So it's a very, very valid technique, at least for the dentin. On the other hand, there was a weakness that was discovered just a little bit later, because I remember early on trying some of these products, and like anything else, we tend to jump to conclusions pretty quickly. And I have to say this really in defense of all of us over here. A lot of times, many of us wind up or start to use products that don't have any kind of track record whatsoever, and then after about 2 or 3 years, we go by a little bit farther and go, you know, by the way, this isn't working, or, you know, I'm having a little bit of problem here. And then the manufacturers kind of go back and they look at things and they say, oh, okay, well, yeah, maybe we need to do something here or there. And this is what we're talking about here when it comes to this 6th generation or these self-etching products. Because using a acidic primer with a lower, with a pH that is higher than that of the typically used phosphoric acid, they discovered that enamel does not etch well, as you can see here. Look at the differences here between phosphoric acid and the difference between a self-etching primer. It's quite clear that the left slide, or the left micrograph that you see on the left over here, is a distinctly better enamel etch pattern than you see on the right. And what we should remember is that in the world of adhesive bonding, it's important to have good bonds to dentin, but if you have enamel, the best thing about enamel is it's a permanent bond for all practical purposes, unlike dentin, which tends to lose its bond values over time. And it makes sense that we should reach for the best values that we possibly can. So what was developed was what we call a selective etch technique, whereby the dentin was etched, or the enamel rather, was etched selectively to promote better adhesion, which it did do. On the other hand, I find this contradictory, because in the aim of developing products that are simple to use, it strikes me as odd that we now have to add a step that this particular class of product was intended to relieve. Furthermore, I find it a little bit difficult in trying to understand how I can successfully rinse phosphoric acid off enamel without removing some of the smear layer itself, which is what this class or this generation of product was intended to do. So I think as we go farther along here, we'll understand today that there are better approaches. Now, doctors for years have always tried to find ways of getting around things that gave them problems. In other words, you know, I'm having sensitivity with some things. Other doctors understand that, you know, or we all understand that bacteria is a problem. Doesn't it make sense, perhaps, that we should try to eliminate as much bacteria as we can using perhaps disinfectants? I'm having sensitivity. On another hand, is there something that can help me with my technique, or is there something that can help me avoid the sensitivity? And I'd like to talk to you a little bit about that, because in my work with dentists over the years, what I do realize, and I can even tell you my whole clinical practice, that I've been in many dental offices where a doctor may have a need for a specific adhesive protocol, and they have to find the kit, they get it out, and the doctor will typically look at the assistant and he says, now, how do we use that? You know, not to be, not to make a joke about that, but I have seen really, really plenty of that. Not only that, but I do know that when you get a product and it's new, you open up the little instruction sheet, and by the time you open it up, it's about the size of a road map with print that's about the size of 5 blood cells. And trying to read through all that and go through all these types of things creates a little bit of an issue. And additionally, doctors will think, well, I don't have enough here. Maybe I should put a little bit more of the primer, the adhesive on here. How long do I thin it? And doctors typically don't time themselves. What I have learned is that we've learned to become, as I say, predictably unpredictable. So I would like to impart some predictability into that by first asking you to read the directions and execute the instructions exactly as they are intended. The reason for this is that when manufacturers develop these products and they show you what their internal testing produces in terms of results, it's based on exactly how they told you how to do it. And when you start applying other techniques that go beyond the simple directions, you're compromising, in most cases, the outcomes that you would expect. Take a look at this just as an example over here. I just took some examples of product A, product B, and product D. And if you will notice, and I will tell you quite honestly, they're the same class of product. But on the other hand, look at how they differ in terms of their applications. All right. One will say rub it in for 20 seconds. Another one will say let it sit there, okay, for 20 seconds. Air dry for X amount of time. Do this and don't do that. It's really, really important that you understand if you will simply follow the instructions, when a problem happens, it's much easier to address that problem because you've established the control from the very beginning. So I would encourage you, and I can say this in a lighthearted way, read the directions. When it comes to dent and bonding, there's a lot of variability associated with it. And let's be frank, there's no one product that can associate or that can be used to address all the conditions that we face. I can tell you, and the research shows us, and all of us should know, because it's actually empirical on our own parts, to understand that the bonding ability to dentin is certainly different from a younger patient than it is to an older patient. What about dentin itself? We treat a lot of different kinds of dentin: sclerotic dentin, reparative dentin, dentin in non-vital teeth. All these things will produce different results. And what about the degradation of bonds over time? You know, here is of late, you know, many dentists, many of us should be aware of the fact that there is enzymatic activity in the tooth producing, for short, MMPs, which are known to degrade bonds over time and which are a function of the self-etch and total etch systems as well. In addition to that, I think we have to understand that to optimize bonding itself, all right, and to create a properly primed and adhesively coated surface, okay, we want to have at least some idea of what that would look like. And what I encourage you to do is when applying these adhesives, and you apply them as directed, and once you thin the solvents out and you disperse the adhesive over the tooth, look at the surface of the tooth itself. If you see a glossy surface there and it looks like a mirror, you have the best situation for bonding. But on some of these sclerotic teeth, some of these teeth with reparative dentin and the like, when you thin that surface out, you may see a matte finish there. And what that's simply telling you is you're going to have weaker bonds in those areas. Not a lot you can do about that, but I think it does make sense that we want to apply best practices principles to create the best bonds possible, particularly for some of the complex clinical situations at hand. And to understand MMPs just a little bit more, as I mentioned, there is a known activation of these matrix metalloproteinases, or MMPs, the easiest way to call them. It simply involves the loss of collagen matrix hybrid layer, okay, through degradation, which diminishes the dentist bond strengths over time. And there have been a lot of studies associated and are currently ongoing today about how to inhibit these exogenous enzymes, okay, or how to use exogenous enzymes, rather, to inhibit the endogenous enzymes to ablate or to negate the action of these MMPs. And if you look through a lot of the studies that are out there, a lot of dentists have tried many, many things. And I think there is a conclusion, at least within a profession, that it appears that chlorhexidine, when properly used, can be successful to that end. So we'll talk a little bit about maybe how we could potentially use that, but I would discourage you from using other things like sodium hypochlorite and the other things that dentists will say, well, empirically I know it can do this and it can do that. Just be aware of the fact that there's been a lot of research done on this, and I think if you stick with the chlorhexidine in a particular sense, although I don't encourage it routinely, you can have success because the literature in fact does support that. So what about these sensitizers and disinfectants? Well, in my view, empirically, many of these things sound fine. Desensitizers tend to cost more because they add one more step to your procedure. What about disinfectants? Well, if I tell you to use chlorhexidine and a dentist gets out over-the-counter chlorhexidine, these may be the kinds of things that are used with patients, that are used for patients, it's say a rinse. And what that may involve, it may involve the oils and flavoring agents that are associated with the chlorhexidines that may interfere with bonds. It's quite clear to me that if you read the directions, and I happen to put up in your upper right-hand corner over here in one of these slides, as you can see here underlined in red, this particular manufacturer specifically requests that you not use disinfectants and desensitizers. And kind of looking through some of the other manufacturers' products, I think you'll see this mentioned more than not. Now, anyone can do anything that you want to do, but I think if we all focus on sound clinical dentistry from the very beginning, clean preparations, a dry field, at least a controllable field where saliva and blood don't have the potential to interfere or create problems with the task at hand. If you want to use chlorhexidine, a product that I do use, I don't necessarily recommend things one way or the other. I just happen to like the dispensing system. Ultradent makes a really nice product called Concepsa Scrub. 2%, I believe, chlorhexidine, and it has an abrasive agent in it that's glass. It's not volcanic ash that you might find in pumice slurry. And it makes for good use if you're concerned about these MMP kinds of concepts over here. As far as bacteria, I can't find a lot of data in the literature that supports the fact that bacteria cause a whole lot of anything, because it's a hard thing to prove. I understand that empirically it makes sense. I can also state pretty clearly that if you use total etch technique, I think it's a pretty good, it has a pretty good bactericidal effect. Again, let's just focus on keeping things simple and work smart, and I think you'll have better success and at a lower cost and produce good outcomes. So, where are we now? Well, as of late, and I'm sure over the last 5 years, many of you have now seen the advent of what's called the universal adhesives, and we're going to discuss that in the following segment. Because many doctors now are asking me, is it time to change? Is this a ripe time for me to consider a product that for all practical purposes amounts to a cocktail of sorts? I call them adhesive cocktails because like a Long Island tea, they got a little bit of this and a little bit of that to eventually get you to whatever end you're deciding to have that particular drink for. And that's what really the universal adhesives are all about. So what is the rationale for use? What kind of trends do we see in the market? Are they effective? And do we have any level of track record? Are they particularly easy to work with? Are they not easy to work with? And how well will they work for me? Well, the rationale behind them, and we've alluded to this already a number of times in this presentation, is looking at the fact that it's a complex world out there, particularly now when we're dealing with materials in the indirect sense that we have to bond to teeth. Because if you will, when we were doing composite restorations, the common technique, which is what I started with, was the 4th gen product, where we used the 3-bottle system of the acid, the primer, and the adhesive, and then you put the composite in. Well, with the advent of the newer materials now, we have to consider now surface pretreatments for these materials, adding more bottles into the process. And quite honestly, it really does get confusing. In my own experiences with dental offices over the years, I've been in dental offices where they minimally have 3 types of adhesive systems for many of the challenges that they face in clinical practice. Repair of restorations, desensitization, pediatric patients, bonding on brackets, bonding indirect restorations, direct restorations. I think you get my point. So we want to go from hopefully the more complicated environment and take a more simplistic approach to what we're doing. And this is where the universal adhesives come into play. I've had the good fortune to work with this particular manufacturer in the development of this product even before it was released to the market. And as you know, I'm a big believer in market presence. I'm a big believer in the integrity of the manufacturer. And I'm a big believer in track records. And I don't think dentists are in any way should feel, how should I say, less than whole if they decide to wait a little bit, you know, before the proof in the pudding is there, so to speak. This particular product, Scotch-bound Universal, was brought to market in 2011. So here we are, 2016. We're pretty well at the 5-year mark with that. You'll also note that there are other products that have come to market, defining themselves as universal adhesives as well. By and large, they all attempt to do the same thing. Use them for any particular procedure that you have at hand, simplifying your portfolios and ultimately lowering cost. Simple to use, containing the agents that are necessary to create bonding interfaces with indirect materials, such as silane and MDP and HEMA. Capable of use, if you will, for any etch method that you choose. Whether you choose to use total, selective, or self-etch, you'll get comparable results. And the fact that they're ethanol-based is something that I do like, because I do find that ethanol can be quite a bit more user-friendly than acetone. One of the things I should mention is that when we were talking about some of these MMPs and the like, there's an influence here on, there's a difference here actually between acetone, which to me arguably is a little bit more quite a bit more technique sensitive than the ethanol-based products. And if you can apply these things in one coat, that's very, very important, because film thickness is critical in these indirect restorations. You know, we can't have film thicknesses of 50 microns and above, because in essence it can prevent this actual seeding of the restoration itself. So we have to have low film thickness. But the one thing I do like about this product, it has a proprietary agent, Vitron, called polymer, which makes for a much more moisture-tolerant situation, and also produces very, very good bond strengths. And this is proprietary to this particular product. This particular product also has a shelf life of 2 years and is a very, very easy system to use. So if we go back and we think about the retrospective that we had, at least initially, when we looked at the overall tensile bond strengths of the previous materials, and I skipped out over here by eliminating 1, 2, and 3. If you look at the universal protocol, in this particular case Scotch-bond, what should be apparent to you is we now, for the first time, maybe have developed simplistic products that can now take us back to the era where we actually had higher bond values. Now keep in mind that tensile bond strengths are not the only way to judge the effectiveness of these things, because we have shear bond strengths as well, and you know, a lot of times there's an interplay between the two. Tensile is a pull-off force. Shear is a function of how the tooth actually functions, and it's a function a lot of times of the preparation. It's also a function of the material. So many of these things kind of come into play. But the good news is here, I think we're getting back to a better situation with these universal adhesives. So going back to the NMP theory, and I think I mentioned this just a little bit earlier, we talked about acetone, and really what acetone is really all about and how it compares to ethanol-based products. I'm a big believer in the ethanol-based products because ethanol and water is a component of ethanol, and the tooth likes water, a lot less technique sensitivity. This is a really nice study here that you can see over here. It appears that the MMP activity is almost absent. In this case, it was comparing Scotch-bound Universal and was looking at another product involving acetone. So if these MMPs kind of come into play and there's something that influences you a little bit in the use of your product, I think it's good news that at least it looks like we have something that can be effective to that end. Furthermore, there's been some discussion now, if, as I mentioned, we're using indirect materials, they require their own separate primers as well. How do these primers hold up in the bottle? That was a big question that I had, at least initially, using these products, because in my clinical experience, and I've been bonding ceramics for the better part of 23 years now, posteriorly in the mouth, is that silane is an exceptionally volatile material. And I know well that one of the first things I did, at least with the early silanes, where the bottles were relatively simplistic, they would incorporate air if the bottle was left open, and silane would go bad very, very quickly. The good news here is it appears that, at least with this particular product, that the fresh product is as effective on the back end after 2 years as it was in the very, very beginning. And of course, the manufacturer has to understand what the proper level of titration for the particular amount of silane. Too much can be not effective, as much as too little can be effective. And apparently, it looks like we've gotten some very good results with this, so that's encouraging news. So what's the bottom line over here? Well, the bottom line is relatively simple. It's about simplification. If in this particular class of product you have an adhesive cement, you have your universal adhesive, your universal primer, if you will, two simple bottles. If you look at all the rest of the systems that you see here, they involve as many as 6 simple steps. And I think reasoning would tell you that the fewer the steps, the shorter the time, the less opportunity for error. In effect, it's a good time to be doing adhesive bonding. And I'd really like to emphasize this because I've been using bonded ceramics for well over 23 years now, posterior and anteriorly in the mouth. And having a good understanding of this is critical to the success that I have had over these years. So I think we're at a very, very good state now where dentists can now actually use these things in their practices if they have held out to this particular point in time. So what are proven strategies for optimizing universal adhesives? I would give you the following tips. I would say if you're going to use a universal adhesive and you have enamel, by all means etch the enamel, because the effectiveness of the agent in a selective etch mode is not like the Gen 6 products. And by the way, I can't really call universal adhesives anymore a generational product because I believe it transcends these generations. It's actually in a class by itself. And it was something that we wished for years and years ago. So I would definitely encourage you to at least follow that statement of etching the enamel. Do not use desensitizers. Right? I just don't think that it's necessary if you're using a good airtight protocol. In my own clinical experience, in my view, in working with clinicians over the years, it's really about technique. And if your technique's bad, the desensitizers really aren't going to help you. Follow directions. What we do know is that these products, the universal adhesives, require aggressive agitation or scrubbing into the dentin to improve the bond values. We've seen this clinically, we've seen this in studies, we've seen this in a number of, in the literature, in the reported values. Most of these products require good agitation on the dentin. The solvent evaporation is critical in this too, because the solvent is water and it's going to be a little slower to evaporate off. The manufacturer may tell you it takes 5 seconds, but I think you need to make the observation on the tooth itself about that. Clinically, at the school, we've asked students to follow the directions. And if you ask a dentist or a student to do something for 5 seconds or 10 seconds, how long do you think they'll do it for? On average, it'll be about 2 or 3. So 5 seconds may seem like a lifetime, but 5 seconds, too, may not be enough. Make the observation on the tooth that the solvent is gone generally when you observe no flow of the adhesive over the surface. And at that point in time, you're going to have as good a bonding surface as you're going to get for the dentin condition that's at hand. And the other thing I would say is that there's a lot of evidence out there that supports the fact now that the self-etchers are generally as effective as the total etch for the universal adhesives, with the added benefit of just requiring less time. So I think we're at a very, very good state. So let's spin through this now and talk about some things that you may not want to talk about, but I'm just going to give you the highlights over here. If you want to avoid problems and you want to have airtight technique, please consider one of these options that you see over here. I've used dams for years, but today the manufacturers produce many devices that can actually really aid you in producing a very, very good result. These products may take time to place, but for the time it takes to place them, you're going to save 3 times of that amount of time on the back end and ensure good, stable results, because isolation is not just cotton rolls. There's a device out there, it's a 3M retraction capsule that I have used for years, which uses, for the last 2 or 3 years rather, which has a narrow cannula that will inject a paste containing aluminum chloride into the sulcus. And I commonly use this pre-placement of my restorations to eliminate the bleeding and to slow curvicular fluid from coming up through the sulcus, particularly when a cord is used in conjunction with this. So I would encourage you to have a look at this particular product because it produces very, very good results. It can be used with or without cord. And as you can see here in the upper slide, it actually has a hydraulic effect to push the gingiva out of the way and create a very, very nice dry state for you, many times without using cord. And you can see the obvious differences over here in the nice dry field, or excuse me, the nice dry preparation and no blood or curvicular fluid coming from the sulcus itself. So let's talk about surface treatments, silane, MDP, and air abrasion, and how this relates to the materials that we have today. Well, glass ceramics are what I have used, as I described to you, for well over 20 years in my clinical practice posteriorly. And the bottom line is, they're not strong materials. Yes, we have higher strength glass materials, and we call them silica glass materials, but by and large, they depend on bonding for their performance over time, even with the high strength, if you will, glass ceramics that are out there today. And having started with CEREC way back when in 1995, I understood the importance of having a good bonding mechanism because it's the reinforcement that defines the performance of the restoration or the restorative material itself. Many of us, though, who now currently use these products or who intend to use these products don't realize that, first of all, that the acid etching component with hydrofluoric acid is a critical element in terms of providing a micromechanical retentive surface for it. Now, understand that it may seem that the acid etching of these particular products is going to be the same for any one product. Please look at the differences here between the products and what the manufacturers recommend. The bottom line is that you can over-etch these materials. In the process of over-etching, you're going to weaken or loosen the glass enough such that you can decrease or diminish the value of the bond itself micromechanically to the glass ceramic surface itself. And we now have a new class of materials that that are gaining popularity. I think have a definitive place in dentistry, such as Vita, Anamic, Lava Ultimate, and Cerasmart. Please note that they're all handled differently. Vita Anamic is a macroscopic feldspathic network with a polymer that's infiltrated into it. The other two products, Lava Ultimate and Cerasmart, are nano-sized particles, and they differ greatly in the sense that you cannot use acid, hydrofluoric acid, to promote a retentive surface on those two materials. And please pay attention to how this is done, and I'll define this here just in a moment. Silane is the one agent that I have the greatest familiarity with because it's a chemical coupler. It's a difunctional molecule that will promote a union between two dissimilar materials on the other end, using the resin component, adhesive resin, in the middle. On the other hand, it is volatile, and as I mentioned, it's easily degraded by prolonged air exposure. So silane is what we need for the glass ceramics, and typically in the past, the silane had to be used as follows. The silane would be applied, fresh silane or 2-bottle product if you want to absolutely assure that your product is going to be fresh. It should be left on the integrity of the restoration for a period of 1 minute and always in a wet state, reapply as necessary, and then forcefully air dry the product. Now, the zirconia oxide ceramics have unique properties, however. Although you have a glass ceramic which is penetrable by the hydrofluoric acid, on the other hand, the oxide ceramics do not have a penetrable surface. Hence, acid has no effect on them. So when doctors now want strength and they want to bond, they now have to consider how the polycrystalline material or the oxide ceramic responds and what's needed for it. And given that we don't have a penetrable surface, what was developed for these products are metal primers. Again, another bottle. Now, the good news is that with the advent of these universal adhesives, both containing MDP and silane, I think we have a benefit here of understanding that if we can have an effective solution without having to drag out extra bottles here, it might be a direction that we want to take. Because MDP also serves another purpose besides promoting a chemical adhesion principle or a chemically active surface to the intaglio of the oxide ceramics. It is also a bond stabilizer, and it also promotes better adhesion to enamel as well. So it makes perfect sense to incorporate that into a universal product. Siliconization is the product that I've used for years. Is my favorite, actually, even over the MDP. And this is a product that was developed by 3M years and years ago. Labs have used this. It's called triple mechanical deposition of silica. If we can apply silica to the surface of anything, silica is glass, it's understood now that if we can do that to a surface such as metal, such as an oxide ceramic, and having a silica-coated surface, we can now use silane as opposed to the MDP to promote a stable bonded surface. And I have found this useful for bonding any type of material. Gold crowns, for instance, that need to be re-cemented because they have poor retention form and a number of other things. These particular materials have been really, this particular technique has been very effective. And what it involves is the kinetic energy of aluminum oxide particle coming out of the nozzle the particle rather is coated with silica, and the kinetic energy of the particle impacting creates not only a rougher surface or a greater surface area for adhesion, but it also lays down a layer of silica over top of that, and I think it's a very nice technique. If you're doing ceramic bonding today, you need to consider having a simple micro etcher in your practice and use a product like cojet sand. Because the physiochemical approach has been well documented in the literature to produce higher bond values than aluminum oxide its own, and the fact that we've used this for a much longer period of time. Not as much is known today about MDP and its overall stability over time. So this is a tried and true system, and I would encourage you to also look at it as well. So, what's the summary over here? In summary, I hope today that we've at least addressed the basic properties of cements and understanding that there needs to be a balance between the material and the technique that we're going to apply. And we're going to address this in the next component of this program. The mouth is a hostile environment, and although I went through it very quickly, I cannot emphasize enough the fact that to control the field, to give yourself the flexibility to use these products properly, instead of having to do a fire drill to get something in and out of the mouth, can be to your benefit. And please encourage the use of the very basics of, even if it's a split dam, to some of these other products that are out there. I'm a big believer in science, and I do clinically practice every day, and I see children, I see patients of all ages, in addition to other things that I do. I've always believed that science rules. As the saying goes, philosophy is what you don't know, science is what you do know. So although empiricism has a place, don't let it rule the day. Universal adhesives offer a great balance now, and I believe a very effective adhesive approach, particularly now that we're at a 5-year mark, and there's a lot of data that's out there, and it suggests to me that dentists would be well advised to begin, if they're not, to begin the thought of incorporating these into their dental practice. Total etch still rules. There's no doubt about that. In my view, and even with the data that we still out here, because it gives us the greatest results overall. And the fact that you can now use it with universal adhesives, we have relatively zero sensitivity with these universal adhesives. I think you have the best performance, the best combination, if you will, of performance balanced with practicality. I hope you enjoyed this program, and I look forward to talking to you in the next. Thank you.